Hello, everyone. My name is Christy Amobi, and I work with Xstrahl. Welcome to our clinical education session today, which will provide a brief overview about benign radiotherapy. Our speaker today is Dr. Richard Shaffer, who not only provides clinical treatment for benign conditions using radiotherapy, but who also is deeply immersed in clinical education initiatives about this topic. We are fortunate to have him here today. He will provide more background on his clinical practice and experience in just a moment. The presentation is approximately 30 minutes with Q&A at the end. Thanks again for your attention, and with that, I'll hand it over to Dr. Shaffer.
Thanks, Christy. I'm going to talk today just to give an introduction about radiotherapy for benign conditions. And I'll just say a little bit about myself first. I'm a UK-based radiation oncologist. I used to work in the NHS, which is the public health system, treating brain tumours, urology and skin. But I've always had an interest in radiotherapy for benign conditions. And it actually started off with a local hand surgeon who sent me a patient with Dupuytren disease. And he said, look, we're not really getting anywhere with surgery. Do you think you can do anything? Apparently they do it in Germany. And that for me is really where it started. And so during the 10 years that I was in the public health system, I was treating a lot of patients with Dupuytren's, Lederhose, plantar fasciitis, heterotopic ossification, and keloids. And then eventually 5 years ago, in 2019, I left and I treated really more of the same, but also went to Germany to learn how to treat patients with low-dose radiotherapy for osteoarthritis and tendinopathy. And I sat through a lot of clinics and went through a lot of literature. And eventually now at this point, I've treated about 3,000 patients with those conditions. And that's become the focus of my career. I also work as medical director for Xstrahl, who make orthovoltage machines that you can use for benign radiotherapy. I'm founder and director of RTABC, the Radiotherapy Academy for Benign Conditions, where we educate radiation oncologists and radiation therapists on how to deliver benign radiotherapy. I've also started the International Organization for Radiotherapy for Benign Conditions and a few other bits and pieces. So today we're going to talk about classification of benign radiotherapy and also how to make treatment decisions. We'll talk in general terms about the principles of low-dose radiotherapy, or LDRT as we call it, a little bit about radiation-induced cancer risk, and also radiotherapy for osteoarthritis and plantar fasciitis, and a little bit at the end about target volumes. So when we think about treatment decisions, it used to be that you would just say, I've got pain, and then you would treat it. Whereas these days, if you have pain, we really try and get a diagnosis before we treat it. And so we're going to talk now about the classification of diagnoses. So as I said, in the sort of old days, it used to be we talked about pain syndrome. So there would be shoulder pain or shoulder syndrome or knee pain or heel pain. But now really we try and get a precise anatomical site for the pain. So it could be the main knee joint between the femur and the tibia. It could be the patellofemoral joint between the kneecap and the femur. It could be the tendon going down from the kneecap, the patella, down to the tibia, the patellar tendon, so it could be a tendinopathy. It could be a bursitis, and there are various ones around the knee. Or it could be other things around the knee, like the menisci or the ligaments, and those are actually things we don't treat with radiotherapy. So just really important to understand where the pathology is. And then we have to think about pathophysiology. So this is a sort of overall classification, and I'll just go through it briefly and talk about the main points. So we really put it into 5 sort of main categories. The first one is hyperproliferative conditions, so benign overgrowth, and that includes Dupuytren's disease, Lederhose disease, keloid scarring. The next one is, let's just call it low-dose radiotherapy for osteoarthritis, tendinopathy, and fasciitis. Then we look at the inflammatory skin conditions, such as psoriasis, eczema, and DSAT, which are treated with a very low energy X-ray of 10 to 20 kV, and also hidradenitis suppurativa, which is more in the sort of normal X-ray range. People know a lot about stereotactic radiotherapy. That can be intracranial or extracranial with high dose diffraction. That's not the focus of what we're talking about today. And then there's this sort of other bucket, which is things that don't really fit into the other categories, such as heterotopic ossification, Graves' orbitopathy, pigmented villonodular synovitis, sialorrhea, Alzheimer's, and so on. But today, really, we're just going to deal with hyperproliferative conditions and degenerative and inflammatory conditions. And degenerative and inflammatory are what we call low-dose radiotherapy. So when we talk about why we're really covering those things, it partly comes down to numbers, because in the German study in 2018, 87% of what they did was low-dose radiotherapy, and another 4% was hyperproliferative. Just to go into a bit of detail, about 1 in 3 of the German centres returned the questionnaire, and they documented more than 30,000 patients treated per year. You could scale that up to 100%, and in an 83 million population in Germany, that would be more than 100,000 patients a year. In the US, that would scale to almost 450,000 patients a year. So these are very large numbers of patients, but as I say, the major sort of opportunity in terms of numbers is low-dose radiotherapy and arguably also hyperproliferative conditions. So again, thinking back to the pathophysiology, we can classify it quite simply. I've color-coded this. So osteoarthritis is one, and that's part of low-dose radiotherapy. The other half of low-dose radiotherapy is tendinopathy and fasciitis. There's then the hyperproliferative conditions, and then the sort of other category. And so if we do that for knee, then you can see that osteoarthritis in blue, so knee osteoarthritis, and that can be of any compartment. Baker's cyst, which is really the synovial sac, which fills with fluid because of inflammation of the synovial sac. You then get the tendinopathy and bursitis, so patellotendinitis and bursitis. And then actually diffuse chondromatosis is a very rare condition, but it's just an example of where you would have a hyperproliferative condition. You can then do that for all the sites around the body. So for knee, you could see it was a bit of a mix. For instance, on the shoulder, really it's mainly tendinopathy. Osteoarthritis is much rarer. Whereas on, for instance, the hand and wrist, it will be hyperproliferative, so particularly Dupuytren's disease, but also osteoarthritis, and tendinopathy is fairly rare. So it sort of varies according to sites. So coming back to the way that we make decisions, so as I said, the old way of doing it is looking at pain, and that tells us about what to do in terms of treatment. Whereas the modern way, we take into account anatomical site and pathophysiology to get a diagnosis, which we then assign an ICD code to. And after that, that tells us about what our treatment is. And of course, we're now going to talk about treatment with radiotherapy. So let's talk a little bit about low-dose radiotherapy and the principles of that. So this is a sort of loose definition, but essentially we tend to use 0.5 to 1 gray per fraction, 6 treatments over 2 to 3 weeks. So that's 2 to 3 treatments per week, with a total dose of, let's say, 3 to 6. Some people say 3 to 8 gray, but you can see a small fraction size and a small total dose. So I've given an example here. If you give it 3 times a week, you can see I've put down Monday, Wednesday, Friday, Monday, Wednesday, Friday. So that'll be over 2 weeks. I then review the patient at 10 to 12 weeks, and one of 3 things will happen. Either their pain's gone completely, they've had a complete response or near complete, at which point you say, well, you've had a good effect, you don't need further treatment. Or they've had a moderate response, in which case you'll continue with the same dose of 3 gray 6 fractions. Or they've had a minimal response, at which point you have to look again at your diagnosis, potentially do further imaging, and or increase the dose to 6 gray. And this is the sort of responses you get. So this slide's about tendinopathy, fasciitis, and bursitis. And you can see there's a lot of patients in the literature. This is, quite large numbers. And the response rate you can see goes from 65 to 85%. It may well be that the sort of variety of response rates is artifactual, because obviously it depends what sort of patients you get in, how chronic it's been, and what other treatments they've had and so on. But essentially a reasonably good response rate in tendinopathy. And similarly in osteoarthritis, you can see it's about a 75% response rate. Again, I think, although there's slight variation, you can see that there's a good pain response in 75% of patients overall. So the next question is, well, okay, you get a pain response, but how long does it actually take to work? And I have to say that's very variable. So I actually treated one of my first patients. I treated a foot, and by the end of the 6 fractions, she'd had a near complete response. So obviously a very quick response. I also treated a patient recently who had an insertional Achilles tendinitis. He had something like 8 out of 10 pain. The first phase didn't give him anything at all. Second phase, it went down to about 5 out of 10. And then he had a third phase, and that went down to 1 to 2 out of 10. So that was really a sort of 6-month course of treatment. So you can see there's great variation. But overall, this is a study of tendinopathy. If you ask patients on the last fraction of radiotherapy, around 5% have got a complete response, and 84% have a partial response. 6 weeks later, that complete response goes up to 17%, and at 2 years, it goes up to 43%. So, but normally I say to patients that the effect of each phase of treatment will be seen at around 8 to 12 weeks. And this is really just a different way of expressing a similar thing. So you can see at baseline, these patients start at 65 out of 100. At the end of the first treatment, it goes down a little bit to 50. At 6 weeks, this is before the second phase, goes down to about 45 to 50. End of the second phase goes down a bit further. 6 weeks after that goes down to roughly 30 out of 100, and long term roughly to 15 out of 100. So you can see it's not exactly a linear change, but over time it does reduce gradually. So just coming on to this sort of quite major issue that people always bring up, so if we're using radiotherapy for non-cancer conditions, for benign conditions, is it going to cause cancer? And I think, clearly that's a very good question, but there's lots of things we need to take into account. First of all, particularly when you're using low-dose radiotherapy of total dose 3 to 6 gray, this is a very, very small dose of radiation, and therefore you get less of a risk with a smaller dose, higher risk with a higher dose. Their age is important. So if you're, let's say, over the age of 60, really the risk is going to be much more minimal. If you're, let's say, under the age of 30, then the risk is going to be much higher. And I put OA versus tendinopathy because, of course, in osteoarthritis, you tend to treat older patients, whereas in tendinopathy, you tend, although not always, to treat younger patients. So you just need to take that into account. The volume of radiated tissue is important, so we just need to minimize the amount of tissue that we treat as much as possible with the ALARA principle. Perhaps the most important thing is the irradiated site, and we have to be really careful not to treat places where there's red bone marrow. So in particular, we don't treat the spine, we don't treat the pelvis, we don't treat the ribs, unless absolutely exceptional circumstances. And if we treat peripheral sites where there's no red bone marrow, and that might be, let's say, the hand and wrist or the elbow, then really the only organ at risk there is skin. I mean, I guess arguably there's bone and there's muscle, but really that's the major issue. And for skin, the risk is of a basal cell carcinoma, which of course doesn't spread, and the risk is about 0.1% lifetime risk, with roughly a 20 to 30 degree latency period. The shoulders and the hips are slightly in the middle because there is bone marrow, although it's only about 1 to 2% of the total body bone marrow, and therefore there's a very, very small risk of hematological malignancy. Another thing, another reason why we don't treat the spine is obviously there's bone marrow there, that gives you risk of hematological malignancy, in other words, leukemia, but the latency for leukemia is much, much less. So even if you're 70 years old, if you treat someone's spine with radiotherapy, because the latency of getting leukemia after radiation is roughly 5 to 10 years, there's still a significant risk. So I mean, if you're treating a 95-year-old in a wheelchair who's in a lot of pain, that's one thing, but you have to think very, very carefully. I would say that I just never treat the spine for benign conditions. So we'll start to talk now about radiotherapy specifically for osteoarthritis. And osteoarthritis is a major issue in the US, but worldwide. In the US, 1 in 7 adults have osteoarthritis. That gives us more than 30 million people with osteoarthritis. And it costs an enormous amount of money. And of course, there's an enormous amount of morbidity associated with it. And, when you have early osteoarthritis, there's plenty of conservative treatments that you can consider. So exercise, weight loss, aids. And also, you should always do those things, but there are also medical treatments. So analgesia, so simple analgesia such as paracetamol, non-steroidals, although we have to take into account the fact that they have gastric side effects, cardiac side effects, and renal side effects. There are obviously creams and ointments, and there are injections. But I have to say, medical treatments don't tend to be very effective. And of course, once these treatments, whether it's conservative or medical, aren't effective anymore, then until you get to the end stage where you might think about a joint replacement, there's not really anything available, and we call that the care gap. So these are patients, enormous numbers of them, who are living every day with pain, disability, and reduction in quality of life. And this really is where radiotherapy comes in. Radiotherapy can fill that gap for people who aren't yet severe enough for surgery, but where the early treatments are not effective or not effective enough. So let's think a little bit about how low-dose radiotherapy works in osteoarthritis. So remember, the low-dose radiotherapy, I called it roughly 0.5 gray, but between 0.3 and 0.7 gray is thought to be the sweet spot. And essentially, it reduces inflammation. And it does that in a number of ways. It reduces the adhesion between the white cells and the cells lining the blood vessels. It reduces the cytokines, the chemicals that are given out, that reduces the pro-inflammatory ones, increases the anti-inflammatory ones, and changes macrophages into an anti-inflammatory phenotype. But it also actually, interestingly, has other effects on the bone cells. So it reduces osteoclastic reabsorption of bone and increased osteoblastic remineralization of bone. So both those effects seem to be in play. So just thinking a little bit about neo-osteoarthritis, just really as an example. So you can see here, these are obviously lots of studies, some of which are very old, some of which are large and small, but it's a total of more than 5,000 patients. A lot of those are case series, but I am going to take you through some randomized trials as well. And the first one I'm going to take you through is the Arthur-Rad trial, which reported, it's a German trial, reported last year. And this is for osteoarthritis of the hands and the knees. And it was an interesting trial looking at a standard dose of radiotherapy, so 3 gray and 6 fractions, versus a very tiny dose of radiotherapy of 0.3 gray and 6 fractions. It was single blinded. There was, as I say, a mix between hands and knees, and the follow-up was a year. And the result was no significant difference in pain response. So that's pretty interesting. If we think that 3 gray and 6 fractions is effective, then that tells us that perhaps a very low dose of radiotherapy might be effective. So this really is hypothesis generating, but it was a pretty interesting thing to present to start. And then we look at the randomized control trials. And until very recently, the only one we had to look at was the Mahler trial. And this was a very, very small trial from the Netherlands, looking at 6 gray and 6 fractions alternate days, using a LINAC, treating grade 1 to 3 Kellgren-Lawrence. So Kellgren-Lawrence is grade 0 is no osteoarthritis, grade 4 is bone on bone. Obviously, it's graded in between, using pain and functional assessments and follow-up up to 12 months. And they actually compared radiotherapy with pretending to give radiotherapy, and they found that they had no benefit. And so that's sort of where we were until recently. But there were a number of issues with this trial. I mean, first of all, it's a tiny trial. Second of all, they demanded a really quite high difference between the groups for it to be a positive trial. They also used suboptimal dosing of radiotherapy. So rather than using 3 gray and 6 fractions, which we think is the sweet spot, they used 6 gray and 6 fractions. And also, perhaps more importantly, they didn't give a second series of radiotherapy. But I think the most important thing is there was a lot of patients who had a very long duration of pain, and in my view, they were just never going to respond to radiotherapy. And also some other details like a lot of patients with erosive osteoarthritis. But anyway, despite all of those things, this was a negative trial. So then, this year, we've seen this trial come from Iran, which on the face of it is pretty similar, relatively similar sample size. They use a slightly more modern dose of radiotherapy with 6 gray total dose with a LINAC, similar sort of Kelvin-Lorentz grade, and also similar sort of assessment. And they did follow up to 6 months. It was also Shaffer trial controlled, but it was a positive trial. So obviously you've got these two competing trials, which are a little different, but not so different. But I think the middle one, the Russian trial, is really, for me, much more interesting. And this is a much bigger trial, 300 patients. They were treated with a slightly different dose of radiotherapy, 0.5 gray fraction, they gave 10 fractions. I mean, in essence, it's a very similar way of treating, really. But they treated much earlier patients. They were also much younger. They were 35 to 40 years old on average. And grade 0 means that actually there was nothing seen on X-ray, but when they looked at the MRI, they could see changes. So that's grade 0 Kelvin-Lorentz, but also grade 1 and 2. Have a similar sort of assessment in terms of function and pain, but also quality of life, disability rate, arthroplasty rate. And they found that all of those things improved. So pain, function, quality of life, both mental and physical, but also disability rate. And there was a trend to reduce arthroplasty rate. I mean, it was actually quite significant, but not statistically significant because there just weren't that many people who actually proceeded to arthroplasty in either group because they were quite young and they were quite low stage. But the follow-up was really long. I mean, it's gone up to actually now 11 years. The control group was Xstrahl, which is glucosamine and chondroitin plus or minus low-dose radiotherapy. Perhaps the most interesting part of this is that, most of the things that people look for is very subjective. So, your patient says, I've got less pain, my function's better. But this really is objective evidence of change. So they did an MRI at the beginning, an MRI at various intervals up to actually 11 years. And what they found is in the low-dose radiotherapy group, compared with no radiotherapy, the cartilage thickness was preserved, there was less synovitis, there were fewer osteophytes, and less bone marrow edema. So for the first time, we're seeing objective evidence of the effectiveness of radiotherapy, not just subjective. So just moving on to actually one of my first patients, and this is a 66-year-old lady who'd had pain for 6 years, and it really, it's not pain that comes and goes. It was pain all the time. Minimal effect from steroid injections, and there wasn't really anything to offer her really. So pain score in the morning 5 out of 10, at night 9 out of 10. I mean, 9 out of 10 pain is very, very painful. So the imaging, you can probably see on the X-ray, there is a slight loss of joint space, but on the MRI, these sort of cloudy areas, that's the T2 signal showing the sort of inflammatory change in the midfoot, that is. So again, there's no joint replacements for the midfoot. So, steroid injections have failed. There's not really much more to offer her. So we planned a treatment, and you can see the DRR on the left, and I'm covering the midfoot. I'm going a little bit down the metatarsals. I actually did cover the upper ankle joint because on examination she had pain when I flexed and extended it, and we didn't need to treat the heels, so I shielded that out. And you can see that we've got a back there. So I treated her with the standard dose of 3 gray and 6 fractions over 2 weeks, reviewed it at 3 months, with a view to possibly giving a second phase. And before the radiotherapy, just to recap, she had 9 out of 10 pain at night, 5 out of 10 in the morning. And she was stiff in the morning, she could only stand for 30 minutes, and really just difficulty in walking. And then 3 months after the first phase, no pain at night at all, no pain in the morning. And the only time she got pain was when she stood for 2 hours, she gets 6 out of 10 pain. So she was able to walk for longer distances, could stand for much longer, swelling also had resolved. And she really just said, look, please, you've done such a good job, but there's still some pain, so give me more radiotherapy. So we did actually end up doing that, and her pain, was relieved further. So let's just move on to plantar fasciitis. So, what is it? I mean, it's also actually called plantar fasciopathy. You sometimes see it called plantar heel spur, or calcaneodynia as sort of heel pain. And really, it's strain and degeneration of the plantar fascia. Very, very common. Actually affects 10% of the population in their lifetime, particularly between the ages of 40 to 60 years old, and it gives you heel pain on the bottom of your heel. So the causes of mechanical overload, and there are various ways that can happen. So wearing poor footwear, doing unaccustomed and or intense exercise, and also being overweight. But most people with plantar fasciitis do get better with conservative measures. So that's resting, stretching, icing, that sort of thing. But if the pain doesn't get better after 3 to 6 months of doing conservative treatment, then that's when we term it resistant plantar fasciitis. And that's really where you need to look for other types of treatment. So this is, again, one of the first patients I treated with plantar fasciitis. She's a 43-year-old female medical secretary, and she'd actually had it for 12 years. And originally it resolved with conservative treatment, and then 10 years ago it occurred, and she tried physio, she tried ultrasound treatment, steroid injections, but when I saw her, she had right heel pain. She was tender in the medial heel, which is very, very typical, and it was also going forwards into the plantar fascia as well, rather than just the insertion. At that time, I was doing a scan on everyone, and I ultrasounded her, and the thickness of the plantar fascia, where it actually inserts into the calcaneus, the heel bone, tells you, is a diagnostic sign. And over 3 to 4 millimeters is positive. She had 6 millimeters, so that was absolutely in keeping with plantar fasciitis. And just to read you her quote, she said, "I've become so desperate for help, I was willing to do anything to give me a better quality of life. It was totally life controlling. It was like walking on needles in my heel. Incredibly painful." So I went through, not in this sort of detail with her, the evidence for radiotherapy for plantar fasciitis. And on the left, you can see up to 2012, there were 13,000 patients in the literature, 85% response rate. And I just done a quick sort of look at what happened since then. And you can see there are almost 10 new studies, about 1,500 patients. So yeah, overall, there's roughly 80–85% response rate. And I thought I'd take you through 2 of these studies, which are randomized trials. So the first one is a German study, 62 patients. And this was a randomized study between standard radiotherapy, which was at the time was 6 Gray and 6 fractions, and very low dose radiotherapy that just wasn't expected to give any response. And these are typical patients, average age 56 years, average duration of heel pain. They'd had it for a long time, 17 months, and pretty severe. 90% of them said they were limited or no ability to do sports. And their visual analog pain score out of 100 was roughly 60 out of 100 to start with in both groups. And you can see that the change in the standard dose radiotherapy group was more than double that of the very low dose radiotherapy group. They then went back to the patients and they said, look, do you think your pain has got better enough, or do you think you want further treatment with radiotherapy? And in the standard group, standard dose group, the proper radiotherapy dose, only 17% of them said that they didn't feel their pain had got better enough and they wanted further treatment. Whereas in the very low dose radiotherapy group, 64% of them said it wasn't good enough. And it was still effective 4 years later and no side effects. And the second study is a Turkish study, and this is 124 patients. They're randomized between radiotherapy standard dose and steroid injections that at various points has been felt to be the standard treatment, although really it's being used less these days. And very similar sort of demographic of the patients. And similarly, the visual analog score was roughly 7 out of 10. And again, there was more than double the reduction in pain score in the radiotherapy group compared with the steroid group. But then if you look at the lower part of the results, you can see the complete and substantial response in the radiotherapy group was 68%, and that compared with 28% in the steroid group. So we can see that radiotherapy is better than steroid injections. So I treated her with radiotherapy, and at 3 months after the second phase, she said, "From not being able to go out for walks prior to radiotherapy, I've now seen a huge improvement, can comfortably walk up to an hour. I've never been this good with regards to my plantar fasciitis in the 12 years I've had it. And I then saw it 14 months, and the heel pain had almost completely resolved, gone down by 80 to 90%, and also in much less restricted area. And this is another pretty famous patient. I saw this patient on TV while I was watching the Bolt documentary. This is Usain Bolt. And suddenly this radiotherapy machine comes up on the screen, and I saw that actually he was treated for heel pain. It's not clear whether it was Achilles tendinitis or plantar fasciitis or both. You can see you've got bolus material, you've got a varying machine there. And then he went on to win further gold medals. So evidently effective here. So I thought next we talk about, how do we actually do this, in terms of fields and volumes. And, there's lots of different ways you can treat with radiotherapy, and they go from the very simple to the very complex, and not to make a judgment about what's better, but just sort of track that through. So you can use a direct field for some conditions. You can use opposing fields, and that can be with kilovoltage, orthovoltage, for instance, using an Xstrahl machine. You can use opposing fields with a megavoltage just on a DRR. You can use opposing fields with megavoltage using a planning CT, so using the slices, or you can use do volumes on megavoltage using a planning CT. So if we look at on the left, you can see direct fields, and you can either do this with kilovoltage or electrons, and you can see the red is basically the field for Dupuytren's disease. You can see I'm missing out various areas, so missing out the carpal tunnel, missing out the thenar eminence, hypothenar eminence, and also missing out the ends of the fingers, to not treat areas where most of the time Dupuytren's doesn't affect. On the right, you can see that this is an anterior field. You would use opposing fields. This is typically for a knee osteoarthritis. You can see there's an Xstrahl machine orthovoltage. I'm just going through the knee in a little bit more detail. So, we've said that really we need to get diagnosis before we treat, and this is just demonstrating how that works. So on the left, you can see knee osteoarthritis. This is a patient with a medial compartment osteoarthritis, grade 3 with infusion. And so that tells us that really the synovial sac is involved in this process, and therefore that's the target. And you can see in purple on the left, I've put where the synovial sac is. I've put basically a lateral field to cover that, which goes a third below the joint line and 2/3 above the joint line. So important to know that it's not symmetrical. Whereas for a retropatellar osteoarthritis with no effusion in particular, you can see really, because it's outside of the joint capsule, you just need to cover effectively the joint with a margin. So that's a much smaller field. And then for a patellar tendinopathy, that's completely different because it's nothing to do with the joint sac or the joint at all. Really, it's about the patellar tendon with a margin. So moving on to megavoltage fields, you can see on the left that this is a megavoltage field with the DRR. You can see it's roughly 2/3 above and a third below for knee osteoarthritis. And then just a little bit more sophisticated on the right, you can see that I've marked with yellow dots. This one's on the top, just the top of the joint capsule, and essentially where the joint capsule is in the other two areas, and just making sure that our field covers those, because you can, of course, personalize it. People are different sizes, people have different configurations. And then you can also go on to megavoltage volumes, and we use the ALARA principles, which is don't treat more than you have to, either with volume or with dose. GTV, CTV, PTV, except instead of tumor, we use target. And you can see in orange, I've got my medial compartment osteoarthritis. I've covered the joint sac with my CTV in purple, and then adding on a margin for internal and external motion for the PTV. So just to tell you about a program that we're running, which is run by the Radiotherapy Academy for Benign Conditions, or RTABC, and really it's taking all these principles. It's in 3 phases. The online component is an immediate phase where there are educational videos and downloadable materials, including patient information leaflets, consent forms, questionnaires, and then a comprehensive set of radiotherapy fields, both for orthovoltage and for megavoltage. The second phase is face-to-face training. We do that in various places, in Europe, the US, and also going to start Australia. And that really goes back to the beginning, to anatomy, physiology, differential diagnosis, going to history examination of the various parts of the body that we treat, looking at imaging, so X-ray and MRI, looking at cases, and then obviously going into the radiotherapy techniques, and that goes into orthovoltage and also 3D contouring. And then there's a mentoring phase for 6 months where when people are actually treating patients, they pre-submit their cases, and then we give feedback and all learn from those cases. So thank you very much for having me to speak, and I'll turn it over to questions.
Thank you so much for that comprehensive presentation, Dr. Shaffer, especially with regard to the clinical evidence. It's really good to see all of this, material in one shot here. So thank you so much. Regarding the treatment grade or the grades of osteoarthritis, Dr. Shaffer, can you comment on what grades of osteoarthritis respond best to LDRT?
Yeah, so I mean, generally, we tend to treat people with grade 2 or 3 osteoarthritis because at that point, they will tend to have significant pain and it's not too late. So we know that grade 4, you get a reduced chance of responding when you've got basically no cartilage there. Therefore, it's what patients call bone on bone. So we don't really treat grade 4. Although, I have treated some patients who are not eligible for surgery because they're too old, too frail, got other sort of comorbidities that stop them from having surgery. But generally, we don't treat grade 4. When we come down to grades 0 and 1, then that really means there's no or minimal changes on the X-ray. And therefore, for those patients, if there's no changes on the X-ray, then often they won't have enough pain really to be worth treating. So that's where we tend to treat, is the grade 2 to 3. However, we know that X-ray changes don't correlate well with pain. And therefore, if we can demonstrate osteoarthritis on an X-ray or an MRI and they have significant pain, we would still treat. But conversely, if someone has very severe osteoarthritis, grade 2 or 3, but it's not painful, we just wouldn't treat it. So it is a combination of grades, but also symptoms.
Yeah, that makes sense. That makes sense. Are you looking at any other comorbidities or treatment history with regard to evaluating patient selection?
Well, I mean, there are certain conditions that mean that you can't treat with radiotherapy at all, certain radiation sensitivity syndromes, so of course that's important. If people have had radiotherapy treatment before, then we take that into account. I mean, it is important to understand that if we're treating someone with osteoarthritis, that we would need to make sure that it actually is osteoarthritis. And so there are, a lot of the time it's very obvious. But for instance, if someone's got erosive disease, or they've got a lot of swelling, or it's affecting joints that you wouldn't expect that pattern to be affected by osteoarthritis, then you may well want to do sort of rheumatological investigations to make sure that it's not an inflammatory arthritis that we wouldn't tend to treat. So I think those tend to be the main things. We're trying not to treat, use a local treatment to treat a systemic condition, which is why we don't treat, psoriatic or rheumatoid arthritis mostly.
Okay, thank you. Are you using any image guidance or specific patient immobilization as part of your benign therapy protocols?
So I think, I don't want to be too prescriptive about this because different people will do different things. If you're using orthovoltage, you don't really need it because your orthovoltage machine actually is the immobilization. It literally touches the area that you're treating, and almost by definition that you're treating the right area, as long as that the patient just doesn't sort of move out of the way. So you don't really need immobilization most of the time for orthovoltage. In LINAC-based treatment, there's a lot of variation in practice, and it used to be that we would do something really crude, like take the hand down or put it on a sandbag. And then, once we were doing more and more of them, we started using vac bags, so to make sure that we had a bit better immobilization. And then really as time's gone on, particularly with hands and feet, we've just found that having a thermoplastic immobilization as well as a vac bag does really add a lot. You know, it can be quite difficult to reproduce position without those things. So, you know, we've moved in our journey, but, you know, that's not to say that that's where everyone needs to start. But I do think that at this point for our practice, that thermoplastic immobilization is very helpful.
Okay, thank you. Next question is about arthritis and the ongoing continuation of the anti-inflammatory medication. So do you continue to have the patients take their medication, you know, during the treatment? How do you handle that as the radiation therapy course begins?
Yeah, I mean, I don't tend to mess around with things. You know, one would hope that if the radiation is effective, that they won't need their non-steroidals anymore. So, you know, naturally, after the treatment, you know, is being effective, then it makes sense to tell the patient to stop taking their anti-inflammatories. But, you know, I guess there are two things to say. First of all, that the patient still needs support during the, you know, the treatment time and in the time where they are getting their response. But actually also there's an interesting other aspect, which is about 1 in 4 people will get a flare in their pain before it gets better. And actually it is a good sign. It actually is a good prognostic sign in terms of then eventually responding. But of course, during that time, they're going to need a little bit more support. So yeah, I tend to continue the non-steroidals. I don't like them having other new treatments near to the radiotherapy. And it's not necessarily that I think they're going to interact with the radiotherapy effect. It's just, you know, if you're giving radiotherapy and then suddenly they have a steroid injection, and then you're seeing the patient 3 months after the radiotherapy to assess if they need a second phase, how are you going to know whether it's the radiotherapy or the steroid injection that was effective? And so I really think that these other treatments just muddy the waters. So I try and avoid getting them done so that I can assess the effect of the radiotherapy properly.
Okay, thank you. Can LDRT be repeated if symptoms occur?
Absolutely. So, you know, the way I think about it is that most patients will need 2 phases of treatment. About 20–30% of people will get enough response. They don't need to actually have the second phase. And maybe 10% of people will actually need a third phase. And that has happened with, let's say, a couple of my patients, but certainly something to bear in mind. So, you know, you can have more than 1 phase, but I regard that all as the sort of primary course of treatment, shall we say. You know, if you're able to give a patient who's got chronic pain a year or 2 of pain relief, I would say we're doing pretty well and the patient will be delighted. But they do get it, you know, potentially their pain may well come back, and absolutely you can repeat the treatment. If you've used 3 gray in the past and that was an effective dose, then I would just, you know, continue with a further 3 gray and 6 fractions. If you had to go up to 6 gray, then probably you would start with that next time. You know, so you would start there, and again, you may well do a second phase in the repeat treatment. Importantly, though, there is a lifetime cumulative dose maximum for each anatomical site, and Degro sets that at 25 or 25 to 30 gray. So you can absolutely, you know, if you're treating different parts of the body, then, you know, you can sort of add that on. But if you're treating a particular area, then there is a dose maximum during people's lifetime.
Okay, gotcha. Next question is around the treatment protocols. You mentioned that you're doing the treatments every other day over the course of a 2 to 3 week period. Have you ever done the fractions every day, you know, and is there any comparison, are there any comparison studies regarding, you know, treatments, you know, giving the fractions every day versus every other day?
So I think the every other day comes from preclinical studies that were done, you know, quite some time ago, German studies. And that really is the way that it is practiced. That said, from memory, I think the Iranian trial actually did do it every day, and that was an effective study for knee osteoarthritis. So, you know, I think it would make most sense to stick to what people are doing and what we know to be effective in the many, many thousands of patients that have been studied. So I wouldn't take, you know, one study of 60 patients as a practice-changing study, and there have not been comparative studies that have been done. But certainly, you know, from my point of view, I would just stick to the every other day or twice a week.
Okay, thank you. Can you comment about your referral strategy?
Sure. I mean, I absolutely can go through where my patients come from, but of course, it's going to be very different in different places. You're going to have different relationships, different setups, and so on. In the UK, about 80% of my patients are self-funding, and 80% of my patients come from direct-to-patient marketing in a loose sense. So it might be that they hear about me from another patient, it might be that they see videos, Facebook groups, or it might be that they actually come straight to my website. So there's a lot of direct-to-patient marketing that happens. I do obviously get sort of repeat customers coming, and I also do get referrals, particularly from hand surgeons, I would say, is my best referrers. Although actually I do get a fair number of keloids as well from dermatologists and plastic surgeons. I always say to people that when you're starting your benign radiotherapy program, one of the best sources is your own patients. So, if you're treating a patient for prostate or breast cancer, it's just ask them, do you have any joint pain? And very often, because of the demographic, because their age and so on, and also because they may all be on hormones that increases joint pain, they may well have osteoarthritis anyway. And also, they trust you, you have that relationship, and also they're used to having radiotherapy already. So that's a very, very good place to start. But coming back to your question, most of my patients are self-funding, direct-to-patient, sort of marketing, as it were, and more of a minority are from referrals. But that said, it's completely the other way in Germany, and I suspect the other way in many other countries.
Yeah, no, I have heard other radiation oncologists who are practicing benign radiotherapy talk about, just asking their current patients, about the pain and pain management. So next question, we have also have a few more minutes for additional questions, so please keep submitting those questions in the GoToWebinar control panel. Next question, is there any difference in response rates according to gender or ethnicity in your experience?
Well, that's a pretty simple answer. There's no clinical evidence, although there may be preclinical evidence for that. So I think at the moment, really we would quote the same response rate, and we would use the same dose and so on. But there may be a slight difference in terms of gender. I mean, the other thing to bring attention to is that there is a question also about age and activity as well. And recently I've started treating more sort of athletes and athletic people for tendinopathies, as well as older patients with osteoarthritis. And and I do wonder, because a lot of the studies have been done in patients who are 50, 60, 70, how one translates that data onto patients who are younger. And certainly we don't want to be treating patients who are too young because of the potential risk of radiation-induced cancer. But on the other hand, people do get plantar fasciitis in their 20s, 30s, 40s. And for people who really have tried every other type of treatment, other than very invasive treatments like surgery, it's something we should consider. And I always wonder whether, the sort of more sedentary people or your weekend warriors are going to potentially react differently to a professional athlete.
Right.
And that would be for two reasons. First of all, a professional athlete puts an enormous amount more pressure and strain on the areas, but also it's very likely they have much, much better support around them from physiotherapists, from other treatments, load management. They may well have better diagnostics, they may have injections, all these things. And so I think that's quite an interesting open question. So I'd love to treat more athletes, but at the moment it just really remains open.
Yeah, with that, the next question is actually specifically about athletes, actually, because you showed the Usain Bolt, image from that 60 Minutes video. In the athletes that you have treated, do you see a positive response in those folks that do have those very sporty lives, and how quickly can they get back to restarting their sports activities?
Yeah, Interestingly, I've actually found that the sports people have tended to have a slightly better response. And I think there are probably a couple of reasons for it. And, I think partly because athletes are just so sensitive to changes and to pain. I mean, I think actually a lot of athletes are very resistant to pain. So they'll keep on playing despite the pain, particularly if you're, if that's your profession. But also, a little bit like I treat a lot of musicians with their hands, and I always say, they always come earlier because there are so many different things that matter about let's say you're a pianist. It's not only about, do you have a contracture from Dupuytren, there's also how about the speed, the power, the coordination, all these things. And I think also, athletes, really pay a lot of attention, as do their medical team. But also, as I say, they have the right support around them. So they're always going to be very, very well looked after with all those, in inverted commas, conservative treatments.
Right.
So, it may well be that they do better. And also we know that people who present more acutely, in other words, particularly within 6 months, but certainly earlier than that, tend to have a better response than those who present later.
Right.
And I think that's probably quite a big dynamic in athletes.
Okay. Thank you. Final question. For plantar fasciitis, could you please elaborate on the need for a bolus? A lot of centers don't have the kilovoltage, options.
Absolutely. So, it depends how you're treating these patients. Essentially, there are two ways of doing it. You can use a direct field, particularly with orthovoltage, but sometimes people use, an electron field or something. You just need to really make sure that your energy is sufficient, and also that you make sure that you're able to treat the depth. This is really it's not do we or don't we use bolus. It's just you need to use bolus when you need to use bolus. But if you're using a parallel pair, I tend not to use bolus for plantar fasciitis, or but taking it in the round, I would say that I tend to have bolus almost as a default now. And the reason is because, if you miss it out and you need it, then it can be quite difficult then to sort of put it back when you've done the immobilization and so on. And, you may well underdose. So, for instance, let's say I'm treating an Achilles tendinitis, I may well not need bolus for an insertion of Achilles where it goes into the heel bone. But because your Achilles becomes quite thin as it goes up the back of your calf, you probably do need build-up to get that dose in there. And so if you're not quite sure exactly what your field or your volume is going to be at the beginning, it just sort of makes sense if you're treating Achilles to then put bolus, so that you don't miss it out. So this is more a sort of standardization issue rather than necessarily you do or you don't need bolus. But, there are definitely things you do. For instance, if you're treating Dupuytrens with electrons, absolutely you need bolus. If you're treating, let's say, a shoulder, the AC joint, generally it would tend to come very close to the surface. Absolutely, you would need bolus if that's the case. So it is going to be a case-by-case thing, but in some ways, unless you're struggling to get depth, then having bolus isn't necessarily going to do you harm.
Okay, thank you so much. On behalf of Xstrahl, I would like to again thank you, Dr. Shaffer, for today's presentation. To the attendees, thank you so much for joining us today. If you have any additional questions, you can always contact us here at Xstrahl, and we can get you in contact with Dr. Shaffer or another person at the company who can help you with your questions. So thank you so much. And with that, I'll close today's session.